Ladies and gentlemen, thank you for joining the Global Health Forum. KOFIH started to organize and host the Global Health Forum every month since last September to lead discussions on global health issues. We hope different ideas and topics suggested through the forum will help raise the value of health cooperation and set the norms in the international community. Today, we are pleased to have Dr. Sabina Faiz Rashid, Dean at BRAC University School of Public Health in Bangladesh. She will give us a presentation under the theme of Lessons from COVID-19, Social Science Research, Placing Communities at the Center for Future Responses. Please welcome her with a big hand.
Well, thank you so much. I'm going to request my colleague Rove to put the slides on the screen, and then I'm going to talk you through it. If you can put it on a window style. So really, I'm a medical anthropologist, critical medical anthropologist, because I do a lot of my work on gender, health, human rights, and poverty. And I've been living and working in Bangladesh since '93. I was at BRAC, the NGO, and then I joined the School of Public Health at BRAC University in 2004. And I've been overseeing the school since 2013. So if you go back to, first of all, I'm going to indicate to you, Rolf, when you need to go to the next slide. So if you could just go back, please, Rolf. And really, this is about lessons for all of us. And for those who already know these lessons, that's great, because it would be great to get your insights and inputs. But I do think that often communities are used as one word, but communities are diverse across the region, even within Bangladesh and even within South Asia. So I'm going to explain why it is so important to have engagement with communities and why social science research methods are so important. Next, Rove, thank you. So social science research usually is on the periphery in pandemic or epidemic responses. And we have lots of very, very useful methodologies. We have surveys, you've got evaluations, got rapid assessments. You can also have rapid social science assessments, but they tend to be in the periphery. And we need to look at how research can contribute to pandemic control by providing better evidence, more nuanced evidence, because it looks in depth into some of the other complicated, messy linkages between different factors that shape health. Secondly, I think with social science research methods, they're also novel methods, and you can have a complementary of multiple methods, interdisciplinary approaches, multidisciplinary approaches, to show you how evidence can inform policies and come up with equitable solutions. Equitable is key here, because equity is at the heart of health. And often health can be biomedicalized, and we forget how economic, social, political factors play a role. Next, thanks. So there's a lot of studies that show, particularly World Bank and others, that COVID will push, because we have, well, it's pushed 49 million into extreme poverty. Middle East and North Africa, extreme poverty is doubled. There's new poor that's concentrated with high poverty rates. Almost half of the projected new poor will be in sub-Saharan Africa, with an additional 16 million South Asia, and there's projections of another 10 million. But what I really want to emphasize, the poverty always was there. It's just exacerbated and magnified the levels of inequalities because the disparities have widened. And many have been left behind. Women, refugees, internally displaced people, people living in slums, which we call informal settlements, remote rural populations, undocumented migrants, migrant workers, African Americans, you can say Hispanic, elderly, informal workers, people living with disabilities, adolescents who dropped out of school, and even LGBTQI communities. Next slide. So why am I talking about these different social groups? Why is it important? Because despite its biological origins of COVID, we really need to understand the pandemic and control and response has to look at primarily human costs. And it requires in-depth knowledge of a broader context. So one context is very important. And I'll show you through pictures later why context is important, because then it makes you understand what is social about the pandemic, what is economic about the pandemic, what is cultural, and the political processes. While COVID research, I was here throughout COVID in the lockdown mode, the focus was mainly a preference for hard sciences, quantitative methods, and clinical trials. That's important. But I strongly believe it only tells you one half of the story. The other half often goes missing because science and medicine do not operate in a vacuum. We really need a broader approach of the course and the continued consequences as of 2023 on people's lives who were impacted by COVID. And there's a real need for social science because you cannot have actionable measures that are applied to real world conditions and contexts are different. What's happening in your country and what's happening in Bangladesh in a rural village and in urban slums are very, very different. I'm sure within even your own country, there's so many differences in terms of people's lifestyles, inequalities amongst poorer groups. I was looking up the underbelly of South Korea, and I was also looking up the underbelly of Japan, which showed there's a whole missing group that are often hidden away. We call them the hidden populations. And they're large numbers who are dealing with other forms of challenges from economic growth. So we need to understand the social drivers of vulnerability and risks during a pandemic. And how does it impact differently on populations and communities? For example, if we look back in the 90s for HIV/AIDS epidemic, eventually institutional responses, policy actors understood that epidemics are very linked to social and cultural phenomena, sexual relationships, intimacy, multiple partners, access to condoms, access to safe spaces. So even COVID is not just a medical issue. And a lot of public health tends to look at medical issues. I'm going to talk a little bit, I'm going to focus mainly on Bangladesh, but also end with some examples from Laos, Philippines, Vietnam, and Singapore, because I was part of the Southeast Asia COVID-19 Social Sciences Working Group, where we brought in case studies to show how social science was either invisibilized or overlooked when we looked at COVID, and why it was so important, and how governments started including social scientists in their task force to have better tailor-made policies. Next, please. So one big public health challenge I would say is that it's a clinician-led approach. So while you had different actors, the focus was primarily around wearing masks, lockdown, and wash hands, and surveillance to ensure this was followed. While that's absolutely important, we have to also understand that you cannot narrow it down to an individual and purely biomedicalize it, because contexts matter, and we have to reframe public health beyond disease. People live in environments, and if we don't understand these environments, some of these clinical acts are either not followed or cannot be followed because of the context of people's lives. So if we want to strengthen public health and clinical responses, we have to really look at circumstances. The first picture shows a crowded Rohingya camp. The second picture shows groups of women who have one or two water sources in their corner to access water. So when we say wash hands frequently, they have water erratically for a few hours, and you have crowds of women lining up to get buckets of water. When you say maintain physical distancing, it's extremely hard in environments when there's very little space or it's not feasible to do so. Next slide. If you look at it, this is a disabled person who was dependent on caregivers. During the initial lockdown, which was about 2 months of rigid lockdown, caregivers could not be near their patients or the ones who relied on them. Then you had rickshaw pullers. There were informal workers who relied every day on a local wage. We have millions of rickshaw pullers who suddenly had no income with the lockdown, and they live in slums. The picture of the women in those crowded spaces. Next slide. Again, you can see groups of people working together, and this is mainly from slums and from camps. Next slide. A pregnant woman wanting to give delivery lives miles away from the clinic, particularly if you're in remote rural areas. And the second picture is of a woman waiting for relief materials in a long queue because they'd finished all their savings. They had no jobs. There were maids, there were drivers, there were housekeepers. They were running around trying to manage from whatever savings they had because the entire country shut down. And they were told, wear masks, wash your hands, and maintain distance. The average household has 6 to 8 people living together. Next slide. This is one of the largest urban informal settlements in Dhaka city. It's got thousands and thousands of households, and it's super congested. So lockdown, while we needed to do the lockdown, they needed other forms of social support, social protection, stipends, continued relief materials and support during this very difficult period. Next slide. So you had millions who were affected, fears of, hunger, there's no income, lockdown. The task force of the Bangladesh government was just doctors, and they took a very biomedical response, which I would argue many cut and pasted from the West, but not realizing we have different health systems, different populations, different needs. And there was a whole reliance on economists and surveys, biomedical, clinical modeling. Social science research, we as social science researchers, along with my colleagues who did surveys, started producing and sharing our evidence on media to civil society. We did a lot of community vulnerable assessments to find out about how the social economic impacts, the reduced food consumption, the mental health, fears around COVID, the lack of trust, and also during vaccine uptake. In Bangladesh, there's a history of successful public health approaches through community engagement, from ORS to family planning to tuberculosis. And we worked across sectors. In fact, we've been featured in Lancet in 2013 because of the successes of what we've done. By 2021, the government formed a coalition of community health workers, but also NGO actors, because they realized you have to work across sectors and you have to have beyond a biomedical response, which is just not the usual messages of wash hands, wear masks, and keep your distance. We needed to do more. And they rolled out an economic stimulus package. Next slide. So poverty and inequalities exist in countries. That's everywhere, and they're vulnerable. There was a national shutdown, as I said, in March. It continued till May. There was surveillance. No one was allowed to leave their homes. The informal sector, which is the 87% of the workforce, particularly in slums, were affected. Informal workers, female-headed households, sex workers, street vendors, rickshaw pullers, day laborers, even garment workers. The government rolled out a stimulus package, as I said, but there was irregularities. Plus, the package was not extended over a long period. But you have to remember, COVID pandemic, particularly for poorer households, there's long-term consequences. Savings, cycle of debts, cycle of loans, trying to manage. Next slide. Our research evidence and from everywhere else found that there was disrupted networks. There was stigma, there was misinformation, people were turning online, people were hiding their symptoms. There was also evictions of suspected COVID victims from their localities. Our health services were wholly unprepared. Other services were denied. So people suffering from other health problems were denied because the entire focus was on COVID, but we didn't have a strong health system and patients were being turned away. Next slide.
The reason I bring in the intersectionality wheel is it's very important in public health to talk about intersections. Intersections means we need to look at the different factors that shape people's lives. Innermost circle looks at an individual's unique circumstances and environments. Second circle looks at aspects of identity, where you are, whether you're a maid or a sex worker or informal worker. It represents your class, your position, your voice, your power. The third circle looks at discrimination affecting your identity. And the final large outermost circle looks at larger forces and structures, laws, policies, capabilities. It could be globalization, it could be historical factors, it could be politics that really impact on how a person is affected and excluded. Next slide. So public health and clinical responses really need to take into account discrimination. When we talk about leaving no one behind, the SDG goals, we really need to understand where are people geographically located, even within a country. Are they in a remote north? Are they in informal slum settlements where services are weak or erratic? Is there discrimination? We know sex workers, trans communities faced a lot of discrimination. They were seen as contagious. People blame them for being carriers. There's also in these households or families, they tend to be much more vulnerable to shocks. Climate change, environmental, and COVID was another huge shock upon existing poverty. Governance is key here, laws, policies, institutions, and could communities participate in the policies that were being unfolded at the time. And there's, of course, the multidimensional aspects of poverty inequities, which is really just beyond how much you earn, but the combined effects of social, economic, and political exclusion that leads to discrimination, that leads to vulnerability to shocks, that leads to a lack of power, but impacts on your right to water, housing, jobs, food, and generally the basic rights of a citizen. Next slide. So let me tell you four stories that I followed families for over 2 years during COVID. So one of the young women was pregnant. Her husband was not working. She was a street vendor. You know, you have street vendors on the streets. They sell flowers. They sell toys. She was unable to sell for many, many months. So by the time she got back on the streets, the cars were not stopping and buying for fear of contagion. Desperate, she started begging. She was also 8 months pregnant, and she was struggling with support, but she needed the money. She started taking loans. And once you start taking loans, you have money lenders who give you loans at high credit. She also borrowed from NGOs, but because she was so poor, she was uncomfortable taking from NGOs, and she preferred money lenders because they give very quick cash, but with high interest. So she kept working in 2021 till she was almost a few weeks before she had to deliver. Then she gave birth to the baby. Later on, when she tried to get vaccinated for newborns, it was difficult because there was delays, because there was a huge impact on all the health services. Then there's Mohit's story, who's living with a disability. He lacks mobility, and they get special stipends during this period of time. But because he was disabled, he couldn't go to the office to get his stipends. And during the intense period during COVID, caregivers were also keeping their distance by either staying outside and there was no rickshaws, there was no transport. And he had no access to information or services. Shahana is another young woman. She's an adolescent. She's below 18 years of age. She didn't have access to ID cards. If you have an ID card, you can apply for relief materials. But because she was below 18, she didn't have an ID card. She could not apply for relief materials, but she was already married with children, and she was desperately looking for work. And so was her husband, who was doing odd jobs, getting caught by the police, being fined, but still looking for work. Finally, during the peak of the COVID, health workers were going door to door from NGOs, but they were discriminated against. And they were looking to give them messaging around COVID, telling them about masks, distributing, but they faced discrimination because they were told, why are you coming to our house door to door when the messaging says physical distancing? You're going to spread COVID. And they were struggling with low quality, initially low quality outfits, PPE to protect them during this period. After a lot of research was done, the government set up a task force to improve the quality of PPE. So these are the different kinds of stories that are often not told, but these are the impacts. If you look at different kinds of people's lives and their stories around vulnerable groups. Mina's a young woman, pregnant, her reproductive health was, compromised. Mohit is someone disabled. Shahana. I collected 84 stories. We also did large-scale surveys. And although the surveys don't capture some of these more complex stories, what we had was stories around the nuances around, lack of food consumption, fear of savings going away, fear of rising debts, fighting for relief materials, irregular sort of, distribution of relief materials, etc., etc. Next slide. Public health needs to be unpacked. What it means that a public health strategies with its siloed approaches, which is clinical, is not the only way to move forward. COVID is a timely reminder we need to move to a new model. We also cannot homogenize communities and the poor. They're diverse, they're different, with varying needs. An informal worker, a young adolescent girl, a sex worker, a female-headed household need customized services, at least support during difficult crisis periods. It's important to look beyond disease approaches and understand personal, social, economic, and structural determinants of health that make groups vulnerable. COVID only amplified existing struggles and harsh realities, and global local analysis and advocacy needs to bring in social science to look at what's going on with COVID. Just because COVID has gone doesn't mean the hardships of many, many vulnerable populations around the world has not reduced. It continues and it's compounded by the after effects of COVID. Next slide. When we were talking to my colleagues in Laos, we were talking to think tank people in universities. They talked about Laos right from the beginning. They had team members from the Prime Minister, social scientists and policymakers. And they said there was a deliberate inclusion of social scientists, which led to the development of 10 policies and 9 measures in response to the pandemic. What they did was the Lao Academy of Social and Economic Sciences brought in multiple research institutes, and they looked at evidence to make policies that fit for small, medium enterprises, for tourism, loans for affected labor forces, and also training for provincial level personnel and private sector. In the Philippines, the University of Philippines, they leverage existing networks to facilitate collaboration and knowledge sharing with government agencies, private sector, academia, and civil society. Education system in public health. We need to develop data science. We need to look at the development of, we talk about economy and health. Usually these operate in silos and policies operate in silos. We need to have stronger interconnectedness in our curricula and our teaching around governance and Islamic issues of concerns, because many factors were cultural. In Bangladesh and other countries, people would say, well, we pray, we worship God, we will not be killed by COVID. And alternatives, we need to just Western perspectives on the pandemic. There were local level solutions people made, local cultural solutions that people looked at. Burial was a huge issue in Bangladesh. People did not want to go to hospitals because they were worried that if they died, they would die alone and they would not get the rituals and the rites. So we needed to have conversations on religious and cultural concerns, which we never did initially. So that kept people away and people didn't report their symptoms. Next slide. We look at Vietnam. Social scientists were only engaged during the 4th wave. Initially, there was just rigid social distancing and lockdowns. And that resulted in many socioeconomic challenges. And they called for the participation of social scientists. There was an official establishment of a COVID-19 Prevention Advisory Board in Ho Chi Minh in July, 8-member board with largely social scientists with expertise in public policy and law, working with doctors, working with the health sector, working with other actors across sectors. They looked at people with disabilities. They looked at multiple studies on human behavior in the face of the pandemic to improve government response. Some other examples are Singapore. As we know, in Singapore, a lot of the migrants that come from Bangladesh, India, and other countries were badly affected. They lived in crowded dormitories. They were high risk, and COVID had spread, and there was a resurgence of cases. And they set up archives to look at, this was done by the Asia Research Institute with more than a dozen ASEAN countries, to show social experiences of COVID so we can learn from each other, because we tend to have selective amnesia. In Bangladesh, our research at the School of Public Health, many other institutes, NGOs, civil society, Bangladesh Health Watch, and many other actors started talking to government, started sharing with media, started sharing evidence. And that's when the government moved away, lockdown, made it partial, started opening up spaces for the garment sector, realized people needed to work to live. That's when the stimulus package was given. There's many other relief materials continued, masks were distributed, information started becoming much more active. Next slide. So what does it mean? It means a couple of things in our context. But I would say public health in general. I was at Harvard and Boston for 3 months as a visiting scientist. Hard sciences predominate. Nothing wrong with hard sciences, but we really need to invest in social science research. But there's a hierarchy of data in public health. And we continue to have a collective amnesia. Ebola, one of the biggest struggles that was faced in Liberia was that people did not want to follow the prevention strategies and the promotion messages because they were worried about burials. So I think if we all work in health, we need to recognize what counts as evidence, and recognition of the powerful impacts of social science research, as well as other methods, hard sciences, quantitative, economists, clinical models, clinical modeling, doctors, other key sectors that play a role in evidence generation, but policy. So we have to move away from generalizing populations, because what happens is we invisibilize vulnerable communities. We homogenize the poor. We can draw on many innovative methods, longitudinal ethnographies, rapid assessments that are qualitative, visual diaries, photo narratives, community-based methods. I would argue it is imperative that we have nuanced and realistic assessments of how COVID is for those who are the most vulnerable, those who are affected by epidemics, but beyond pandemics, the crisis of everyday life due to poverty. Next slide. Multidisciplinary and interdisciplinary approaches are important. We need to integrate research models. Usually we operate in silos, or we have what we call mixed methods, where surveys are done and you've got some qualitative methods or quotes added in to really complement, but it's sort of tokenistic inclusion. We really need to unpack these disciplinary silos. We need greater investments in our own countries, from our own governments and our own states, to bring about these shifts in sectors and institutional structures, to break these hierarchies, so we can truly work together and bring about rich evidence to inform policies. We need to share and learn from each other, which means building capacity, knowledge, know-how, development of research protocols, tools, mechanisms, and research infrastructure. And training and capacity development together are key. Next slide. You know, one thing that is absolutely important is that we don't talk about communities. And we really need to have, not only in the scientific inclusion of scientists, but in many, if you look at Bangladesh's history of family planning and TB that worked, communities were key. We worked with communities. We had communities inform us about programs and policies and information. And I think we need to push donors and funders to have more research funding opportunities in social science. We need to have research policy interactions at different levels, beyond the local, global. Because in many cases, Taiwan, or in other cases, Senegal, had done a good job of managing COVID, but in the global world, there was hardly any discussions about these other actors, because there's a Eurocentric skewed knowledge of, well, disease is in Asia or poorer countries in Asia and Africa, but not for Italy and not for New York and not for Europe. I think we need to really challenge some of these knowledge hierarchies, but also a hangover of colonization of those who are capable and those who are incapable. We need to reflect and inform broader debates on how to place knowledge, context from within our own countries, across countries, within the region, and collaborate with not only social scientists, but other sectors, but especially communities, to build more resilient societies, because contexts are very important to understand what's required in terms of technology or needs, or what's the know-how, or what are the gaps, or what are the priorities. Next. As I just said, communities cannot be just objects of intervention. Social sciences are key to provide evidence on human beings, human lives, on the social, economic, political, psychological aspects and cultural determinants of health and society resilience within and across countries. They play a key role, social science, during normal times, but also during crisis. And I think it's critical. If we don't include community engagement, if you don't have community-led solutions, irrespective of communities, it could be health providers who have their own solutions within their own health workforce, clinics, facilities. It is absolutely imperative and critical for future policies and programs. And we have to remember, when I say communities, they're heterogeneous, they're diverse, and an intersectional lens of where you're located, your age, your sex, your gender, whether you're elderly, whether you're a widow, whether you're poor, whether you work in a remote area, whether you have very little money, whether you're homeless, is very important to understand effects and vulnerabilities. And I think what I would argue is there's a paradigm shift required, and we need to repack and critically look at what is data, value of data, and and integrate our frameworks, break down the silos, because this will shape better responses for our future. Next, I think this is the last slide. Thank you. Can you shut it down? Next slide. Thank you very much.
Thank you, Doctor, for your insightful presentation. For those of you joining us today, if you have any question regarding the presentation, please leave your question on the chat box.
Thank you very much for your impressive presentation today. I have a question on now we need to have an impact to longer term COVID effect, especially for children, educational or cognitive impact, and also mental health. Do you have any plan?
So, for us, we've started working a lot on mental health because it's neglected. People don't look how important emotional and mental well-being is. Even before mental, the emotional distress that people have suffered in around the world, suicides are up globally. In Bangladesh, suicides are up. Unfortunately, I would say we're very slow in terms of services, the provision of services, there's some very good psychiatrists and counselors. Often it's out of reach for the average person. But BRAC, the NGO that set up the university, they have some excellent work that they're doing in Institute BIED. They've trained para-counselors from within the community to serve the Rohingya refugees. And they also work on early childhood development and cognitive sort of functioning, but it's not my field, early childhood or children. But I do think what you raise is a lot of other kinds of health, public health, critical, emerging, or issues that are being compounded, right? One after another. School closures means many young girls went back into the labor force, and many of them got married because they're poor. And our school closure went on for 2 years. 2 years, and then they opened up online. But online access is for who? Those who are slightly better off. The poorest who don't have internets, laptops, or one phone is shared by 5 household members cannot study online. Whereas before they would go to the classroom. What BRAC and some other organizations did, they had teachers go door to door when the peak of the pandemic stopped to encourage continued learning. But these are important, but I still think so much needs to be done. I don't know if you've read, I'm slightly going off tangent, but if you've read Matthew Desmond, he writes about poverty by America. And he talks about there's a whole millions and billions of marginalized groups all over the world who've been badly affected. So you've got America, which is one of the richest countries in the world, that has a huge belly of an underclass, which don't have housing, food security, are homeless, maybe evicted. Forget health, forget education. There's just nothing going on. And I think COVID is a timely reminder that even our policies need to stop looking at economically, we have this $1 trillion growth. We need to bring in social aspects of social indicators of where we're at. We need to look at other aspects more holistically when we actually say a country is an exemplar example. We need to bring out those uncomfortable truths that we're all grappling with in different ways, in diverse ways in these scenarios. I hope that answers your question. I tried.
Is there anyone who want to make any question? Or if you have any, please wave your hand or leave your question on the chat box.
You can email me if you're not comfortable asking me questions. I'm quite happy to respond later, whatever you're comfortable with.
Now, if there is no one who wants to make any question, now it's time for us to wrap up the session. Once again, please give a big hand to Dr. Sabina Faiz Rashid for her insightful presentation.
Thank you so much for giving me the opportunity to present, and I hope to learn one day about some of the work that you all are all doing. Thank you so much. My honor. Stay safe.
And thank you all for joining us today. The next Global Health Forum will be held in May, and I kindly invite your active participation. Thank you all of you.